clinician and at EMED. So anybody who starts a GLP-1 without having biomarkers tested, you don't know what your baseline is. You might know your weight, and that's about it. So you really need to have blood tests done, whether you're doing it through the EMED program or through your physician. You need to know where you're starting. Are you pre-diabetic? Do you have a poor lipid profile? Do you have familial hypercholesterolemia? There's so many questions. Do you have inflammation? I mean, we know now. We used to have a slide when I started GLP-1s of like what it could treat, and now the slide just goes on and on and on and on. So we know it reduces metastases in some cancers. We know that it decreases inflammation. So not just losing weight and improving your knee because you're bearing less weight on your knee. We have studies that are going to come out now that are going to show that the GLP-1s have anti-inflammatory properties that actually decrease inflammation in your body, and you're probably going to be less likely to get a knee replacement for those two reasons, not just the weight loss. So there's so many things, and I think that what I see is people coming onto EMED who are very used to getting a prescription for 12 months. The doctor doesn't want to deal with the insurance companies. They don't want to have to get the prior authorization every month, and really your dose should be titrated every month to every 3 or 4 months at least. And they need to hire extra staff, like a physician at a hospital or a private practice doctor needs somebody, if they take insurance, to be on the phone all day to get prior authorization for maybe 3 prescriptions. So you need a whole salary for another person to get the prior authorizations for these drugs. There are so many roadblocks. And I think it's going to change. I think as the insurance companies realize that the cost of these drugs are coming down, but the cost of the other drugs and the other admissions, GLP-1s reduce MACE, major adverse cardiovascular events, which by 20 to 30% in some studies. So that's a huge savings to an insurance company, to an employer who's paying for insurance. So I just think that we have to do these rigorous trials because we need to convince people that they're just not a vanity drug.
So to summarize all that, it sounds like, and I totally agree, but the cost of the drugs have come down. There are prior authorizations, which is when the physician, and I do this a ton, and I'm sure you have, asks for permission from the insurance company to actually prescribe something and get clearance for it. And the benefit of spending that extra few dollars a month on the GLP-1s, to us, but what I actually have to document, the benefit is so great because you can reduce other health or outcomes, what we said MACE. So heart disease goes down, right? In some cancers, it sounds like we may be slowing the progression of it. And so that's the benefit that I see also from my lens as a doc, that now we can prescribe something that has all these other secondary benefits. So that's a great example of population health intervention where a drug can actually help reduce other health outcomes, potentially hospitalizations, etc. Everything has a risk benefits. There are risks to every drug. Whenever there's a benefit, whether it's talking about a medication that's FDA approved or a supplement, there are going to be adverse events, right? And so it's all a risk-benefit calculation. And that's something that you have to take into account when thinking about population health, right? We could talk about, mammograms and how effective they are, but do we potentially overdiagnose something and therefore you have bad outcomes, right? So that is what population health is all about, and public health is as well.
But I think now with telehealth programs, we can reach people who never had access. There's no democracy in healthcare in this country, right? Healthcare is not a right in the United States; it's a privilege, and there are many people who have been disenfranchised and couldn't get the care that they needed. And with telehealth programs and apps, people can stay at home and see a cardiologist. People can stay at home and speak with an obesity medicine specialist. They can do a blood test at home from a Tasso device, and they can see if they're pre-diabetic or if they're already diabetic. Things that they never would have known, because many people in America, if they don't go to work, they don't get paid for that work. They can't afford to take a day off. They can't afford the babysitter to stay home with the kids. So population health, with the advance of technology, is really going to change the face of getting access to people who never had access to a drug. But with that, like you said, you need to have supervision and oversight.
So I'll move away a little bit from the GLP-1 because this topic is the future of population health and preventive care. And it's not all just one magic bullet. I think that